Mihir Sarkar, please start.
Yes. So very good evening to all. So from the West Bengal Academy of Pediatrics, today we are going to start our fourth online symposium. And previous three was very successful, and on the demand of the participants, this time we are going for our online EEG Symposium. As you know, the EEG is one of the important basic electrophysiological investigations that we have to do in a child presenting with paroxysmal events. And as clinician, we should know something basics of this EEG and how to get clues and information from the pages of the zigzag line, as a general pediatricians and the resident should know about it. So for this reason, we have taken this academic program for today's the online EEG Symposium, which is the brainchild of our president of West Bengal Academy of Pediatrics, Professor Kalpana Datta Madam, and our scientific chairperson, Professor Sapon Kumar Roy. So I will request now Professor Kalpana Datta Madam to welcome all our distinguished faculties and the delegates and coordinators for this online EEG Symposium. Over to you, Madam.
Okay, thank you, Dr. Mihir. For your nice initial words, and a very good evening to everyone. Warm good evening, and I welcome all to this platform of our EEG Symposia, and I welcome Dr. Mihir, Dr. Rajneet Kumar, Dr. Suman Das, Dr. Sapon Kumar Roy, our scientific chairperson, Dr. Juhi Gupta is our today's speaker, and Dr. Sangeeta. And I think Dr. Sonali has also joined. Welcome you all in this platform. And I welcome all the delegates. You will be, I'm sure you will be benefited by today's and tomorrow's session. And today we will have last day you have a quiz or not? Did you keep the quiz is there?
No, this time I have not kept quiz.
Okay. Yeah. So in the last few webinars, we had a quiz, and that was very interesting also. So in the next webinars we might have. But the EEG is a very difficult subject for if you don't know the basics. So it's very important to know the basics of the EEG. What is EEG? When to write the EEG, how to write the equation, that is important. Whether it is in sleep or awake and both, or with drugs, without drugs. And this is during conversion, after conversion, there are lots of confusions are there. And I think you all will have a clear conception after this workshop. And you ask the questions in chat box. Please mute yourself. Who are the speakers? They will unmute themselves. Otherwise, you will mute all other panelists. Mute themselves. And I think the audience, they can write a questions in the chat box. So go on writing the questions in the chat box if you have any queries. And even in the WhatsApp group created by Dr. Mihir, you can ask the questions over there also. So without wasting much time, I welcome Dr. Juhi, and she is today's speaker and very known pediatric neurologist. And I will request Dr. Sapon Kumar Roy, our scientific chairperson, to say a few words and then hand over to the moderator. Thank you for giving me this opportunity to speak on.
Thank you, Professor Datta. In fact, I am welcoming all the panelists from outside West Bengal, particularly Juhi Madam, Dr. Sangeeta, and Dr. Ranjit, Dr. Sonali Singh, and all. And I can see Joshodhara has also joined. So today we will have another symposium. I'll request all the participants, what you want next, you can share in the WhatsApp group or in the chat box also. So I'll request Dr. Suman Das to moderate this session. This will be a very interesting session today and tomorrow. So over to you, Dr. Suman Das.
Thank you, sir. Now, for today's session, we have arranged about the normal patterns of EEG. Now, the electroencephalography, it has always been an important investigation for the diagnosis of brain disorders, and the interpretation of this requires the knowledge of the electrophysiological phenomena of the brain. Although the formal training is usually received in the neurology curriculum, but the simplified approach needs to be shared with the physicians, the pediatricians, and the psychiatrists, because these specialties, although they are not exposed to the teachings, but the understanding of the basics would certainly be relevant in their clinical practice. Now, to understand what is abnormal, we need to be versed with what is normal, what are the variants of normal, and what are the right machine settings of the EEG. And in this initiative of the West Bengal Academy of Pediatrics, I have arranged two young but extremely eminent pediatric neurologists to guide us all through the lanes and by-lanes of the cortical circuitry. Now, to overview the entire proceedings, it is even more worthy to welcome the chairperson, Her Highness Dr. Sangeeta Yoganathan, the professor of pediatric neurology at CMC Vellore. Now, our first speaker would be Dr. Juhi Gupta. She has done her MBBS from St. GS, her MD from Lady Hardinge, and her DM from AIMS. She is the chair of the current FLICNA Executive Committee. She is the recipient of the PN Taneja Award for her study on transcranial magnetic stimulation. She had received her travel grant for the International Child Neuro Congress at Amsterdam. She's also the recipient of the Kishore Vaigyanik Prathashtan Yogna, and she is also a part of the international trial on Rett syndrome, which is a multicentric study. Our second speaker would be Dr. Sonali Singh. She is currently the Epilepsy Fellow at Toronto Sick Kids Hospital. She is also an executive member of the FLICNA. She has over 20 publications, and her research interest lies in epilepsy and neuromuscular disorders. Now, I would now hand over the session to the first speaker, Dr. Juhi Gupta. Dr. Juhi, please.
And
Thank you
Dr.
so much.
Chairperson, I think Chairperson will say something.
Good evening, everyone. I think it's a great effort and initiative from your team to organize this webinar series for the MD residents. And I'm sure that Dr. Sonali and Dr. Juhi will take us through the basics of EEG recording and steps of recording interpretation as well. Over to Dr. Juhi.
Thank you so much. Thank you, Dr. Suman Das, for such a kind introduction. And I thank the West Bengal Academy of Pediatrics for this opportunity, and Dr. Kalpana Datta and Dr. Sopan Ray sir for this opportunity. So without wasting time, I'll start to share my screen. Are you able to see my screen?
Yes, yes.
Yeah. Okay. So in this brief presentation, I will try to take you through the basics of EEG, and I'll be covering the history in a brief slides. What is the source of EEG potentials, the parts of a EEG machine, how the EEG is acquired, what are the settings of an EEG that you should look at, and what are the indications of EEG. Am I audible, Dr. Das?
Yes, you are audible. Yeah, Dr. J.
Yes, you are audible. Please continue, Dr. Juhi.
Okay, so the history of EEG is very interesting, and I don't have many slides on them, but would like to talk about it in brief. So the history of EEG actually dates back to 17th century, when the eminent scientist Benjamin Franklin could trap these discharges in a Leyden jar. Thereafter, after almost a century, in 1875, it was a British physician, Richard Caton, who could demonstrate electrical activity from animal brain using a galvanometer. And it was only after 50 years that the first human EEG was recorded by Hans Berger in 1924. And to know the story of Hans Berger is very interesting. So Hans Berger was actually a German neuropsychiatrist who could record the first EEG. So that was the era of World War I, and several patients had large skull defects. But Dr. Berger found that recordings could be made just as well through the intact skull. So he recorded the first EEG. You can see the graph below, wherein you can see alpha activity. So he was the first person to record alpha rhythm. But he was a person who hardly ever attended the scientific meetings of his community. And it took him almost 5 years to come up with his findings in 1929, wherein he published his findings and he described the alpha rhythm along with the blocking response. And this was how his old machine used to look like and his laboratory. And
This was not very well liked by his peers, and he was actually given a retirement soon after. Then gradually, starting from Europe, the EEG science started spreading to America. And some of you who are hearing this talk would have heard the characteristic EEG finding of West syndrome, which is Hips arrhythmia, which was described by this couple, Gibbs and Gibbs. So Dr. Frederick Gibbs and his wife, Erna Gibbs, were the first ones to describe Hips arrhythmia, and along with Dr. Lennox. So some of you would have heard the name Lennox-Gastaut syndrome. So these three scientists were working in a team in the US, and around 1935, in the 19th century, a lot of research started happening on EEG in the US. And the classical 3 Hz spike wave complexes were also described by this trio. After around 20 years, EEG became a household word, so much so that in today's times, when we order an EEG and when we tell a patient to get an EEG done, most of them are well versed with it. And by 1947, by the time our country was becoming independent, the American Clinical Neurophysiology Society, ACNS, was founded. So this is a society whose guidelines we follow. I'll be talking about these guidelines in my subsequent slides. And I would like to mention a prominent Austrian neurologist, Ernst Niedermeyer, who also contributed in a big way to the EEG science. And many of my slides are from the book written by Dr. Niedermeyer. And then when I was reading about the history of EEG in India, I found this interesting article which showed a photo of Calcutta Medical College, telling that it was one of the first medical colleges established. And today we are holding this webinar in this beautiful city of Kolkata. And in India, the first EEG was recorded by Dr. Narasimhan in 1950 in Chennai. So coming to the next part, what is the source of these electric potentials recorded from the scalp? So it is the combined electrical activity of more than 10⁸ neurons in the cortex, which are vertically arranged in the layers 3, 5, and 6. And of course, there are local generators of these spikes and there are distant generators. And the current flow which is happening within the cell, which is the primary current, is actually recorded by a machine known as MEG, magnetoencephalography. And what we record in EEG, which is electroencephalography, is actually the current flow outside the cell, which is the secondary current. So MEG is a machine which is a part of epilepsy surgery workup. In many patients who are worked up for epilepsy surgery, a MEG study is ordered. But today we'll focus on EEG. So regarding EEG physiology, so the basis of EEG potentials extends not only to the action potentials of these cells, but also to the synaptic currents, the gap junction coupling, and of course also the non-neuronal currents. It's not only the neural cells, but also the glial networks which contribute to these currents. And the cellular basis, apart from pyramidal cells, also includes basket cells, which are also known as fast spiking interneurons. So what is the basic mechanism of spike and wave generation? This is what we look at. When we are shown an EEG graph, we try to look at spike and wave complexes. So they say that if you have a depolarization in the superficial lamina, then you get a surface negative field. So this upward deflection, this is known as surface negative, and the downward deflection is known as surface positive. So if the superficial lamina is depolarizing, we get a surface negative field and a deep positive field. If the superficial lamina, there is depolarization of the deep lamina, then you get a surface positive field, this one. So in a seizure, when you have a rapid depolarization and repolarization, that's when you get a upward and then a downward and then a upward deflection, which is a spike and wave generation. So coming to the terminology, if you're calling it spike and wave, then the duration of the spike should be less than 70 milliseconds. If it is more than 70 milliseconds, but less than 200 milliseconds, this is sharp wave. And if it extends to more than 200 milliseconds, it is slow wave. Regarding source localization, so as you would know that we are applying the electrodes on the scalp. So the parts of the brain which are superficial, the lateral temporal cortex, frontal, central, parietal, and occipital cortex, they are in direct contact with the skull. So they will generate radial fields. And the deeper parts of the cortex, like the temporal base, the superior temporal plane, and the temporal tip, they will generate tangential fields. I will not talk in detail about tangential fields. They'll be included in subsequent talks. So coming to the next part, what are the parts of a EEG machine? So many a times patients walk up to us taking those large, sort of like this, large paper-based records. So that was the time of analog EEG. This is how an analog EEG machine used to look like. But this is, in today's times, digital EEG is the standard of care. And digital EEG should be done in today's times. So what is the difference between a digital EEG and an analog EEG? This is how a typical digital EEG machine looks like. In a digital EEG, you can remontage the data. We will discuss about montages and you will then understand. But in a digital EEG, if you want to change the montage in C, you can do that. The data can be refiltered. We can change the filter settings. I will discuss about filters. You can adjust the sensitivity also, which I'll discuss in the settings. So overall, basically the data can be post-processed in a digital machine. While in an analog machine, once recorded, we have to see it on the paper. So in analog machine, you have an analog amplifier, which gives the signal to the analog pen writing system, and then it is converted to paper record. While in a digital machine, the analog signal is converted to a digital signal, and what you get is a video display. So this is how a typical modern machine looks like. So this is the patient which is hooked to the machine. The electrodes go to a jack box, which in turn go to an amplifier. And in the end, you have a monitor. You have the keyboard, of course, the printer and the CPU along with it. And the very important, and of course, you have video camera. Most of the machines have attached video camera. And video EEG actually refers to a long EEG record along with a simultaneous video, which is very important to capture the events of the patient. But many a times we do not have access to the video records. Sometimes we only have the rest of the digital graph with us. So I would like to talk about one part of the EEG machine, which is very important, digital EEG machine, which is the differential amplifier. The amplifier in these machines is actually a differential amplifier. And by that, I mean that suppose you have two electrodes, electrode 1 and 2. This amplifier subtracts the signal of electrode 2 from 1 and then shows you a graph. For example, the potential at one electrode is 7 and the other is 0 microvolts. It will show a upward deflection. If the voltages at both the electrodes is similar, it will not show any deflection. And if the second electrode is in even negative 7 microvolt at one and minus 7 at the second, it will show a bigger deflection. So differential amplifier means that it is showing you a differential output in reference to another electrode. So these are the electrodes which have a common reference, which is here, the reference. And the amplifier is actually subtracting that reference from each and then showing you a display. We'll discuss more about it. But while buying any EEG machine, you should always look at CMRR, which is common mode rejection ratio. The value for an amplifier, the ability of an amplifier to minimize noise. And ideally, it is infinite, but a typical value should be 100 decibels. Looking at the electrodes, so there are many types of electrodes. In scalp EEG, we have needle electrode, patch, cup, disc, and others. In intracranial, which is invasive EEG, we have scalp and depth electrodes. But most commonly, we use these type of electrodes. These are cup electrodes. And as per guidelines, silver chloride or gold disc electrodes are recommended. And to decrease noise, these electrodes must be kept clean. So EEG, after doing every EEG, you can have these electrodes dipped into water so that they are kept clean of the gel that you're using. And the electrode impedance should be less than 5 kilo ohms. So let's look at how the EEG is acquired. So to acquire a EEG, you need to place electrodes on the scalp, and we follow something known as International 1020 system of electrode placement. So you have two reference points, which is nasion and inion. So if you start from the nasion, then the first electrode is placed at the 10% distance of the entire semicircle, which is FP2 and here FP1. So all the odd numbers are on the left side, all the even numbers are on the right side, and the central electrodes are FZ, CZ, and PZ. So 10% on either side of nasion, you are placing frontopolar 1 and frontopolar 2. And then at 20%, you are placing F8, T4, T6, O2. And then at another 10% to the inion, you are placing O2. So at 10% from the inion, you are placing O1 and O2, and the rest are at 20%. And similarly for this arc, the FP1 and FZ distance is 20%. Similarly for FZ, CZ, CZ, PZ, and CZ, O1. Let me tell you in simpler terms. So you have these two reference marks. You have the nasion, inion, and you have the preauricular point. And then you calculate the distance and place it. The front electrodes are known as frontopolar. These middle ones are known as frontal. The central ones as central. On the sides, you have temporal. Behind, you have occipital. And on the parietal area, the parietal. So these electrodes, there are 21 electrodes in total. And they are known as FP1 and FP2 for frontopolar. F7 and F8 are anterior temporal. The F3, FZ, and F4 are frontal. C3, CZ, and C4 are central. T3 and T5 are temporal. P3, PZ, P4 are parietal, and O1 and O2 are occipital. So most of the alphabets and numbers are easy to remember. And just try to remember that the odd ones are the left and the even ones are the right. And A1 and A2 are the two electrodes placed on the mastoid process. So this is again a summary of all the electrodes which are placed. So this is how typically a digital EEG machine recording looks like. The setup looks like that the child lies on a bed and you are applying the electrodes using a gel, and they go to a jack box, and you have the laptop with you wherein you can report the EEG. You can record it, and thereafter you can report it and take a printout of the report. And usually a gel, conductive gel is used to place these electrodes. A gel or a collodion can be used, but commonly the gel is used. There are certain additional electrodes which can be placed in addition to these 10-20 electrodes, which are known as sphenoidal, nasopharyngeal, supraorbital, nasoethmoidal, and certain channels like EMG and EKG. But these electrodes are used for certain special cases. Routinely, we do not place these electrodes. So coming to the next part, what are the settings of a typical EEG? So to understand the settings, let us get familiar with 2 or 3 terminologies. What is a channel? So far I've been discussing about electrodes. So 2 electrodes form a channel. For example, C4 and P4 together form a channel. Okay. And because in a differential amplifier, the similar signals are cancelled and the differences are amplified. So what you look at in the EEG graph are the channels. The contiguous pair of channels form a chain, and the chains are then arranged to form a montage. So EEG channel comprises of potential at electrode 1 minus the potential electrode 2. Okay. So if the potential at electrode 1 is more negative than potential electrode 2, it will be displayed as a upward deflection. And the conversely, if you will have the E1, it is at a higher potential, you will have a downward deflection. So minimum of 16 channels are required for each EEG recording. And what you're trying to look at is a phase reversal in a bipolar montage. I'll discuss subsequently. And you're trying to look at the amplitude measurement on a referential montage. We'll discuss these montages. So coming to the montages. So broadly, the montages are classified into bipolar and referential montages. So bipolar montages can be transverse, longitudinal, or circular. referential montages are average reference, unipolar or monopolar, contralateral here. And Laplacian montages are somewhere between the bipolar and reference, wherein you have the weighted average of voltages from surrounding electrodes of a particular electrode as a local reference. But broadly, I would recommend that you can try to remember the bipolar and the reference montage. So let's try to understand these montages. So first, let's discuss what's a reference montage. So in reference montage, the voltage at each electrode is displayed with respect to a common electrode, which is the reference. So the reference electrode can be A1 and A2, which is ipsilateral here, the same side here. For example, to the right electrodes, the right ear, the left-sided electrodes, the left ear. The contralateral here, or it could be very commonly used montage is average reference, wherein you are averaging the voltage in all the active scalp electrodes. It could be a linked ear reference montage or a CZ montage. So let's try to look at these graphs. So herein you are seeing different channels. These are the left-sided channels. These are the even numbers to the right-sided, and the reference montage is the average montage. So let's try to look at this EEG epoch. So here, if you see, you have this FP1, F7, T3, T5, O1. So these are all the odd number electrodes. So these are the left hemispheric electrodes, and each channel, each electrode is in reference to the average reference. So this is how a typical reference montage looks like. And you will have this written on the EEG graph. So whenever you're trying to interpret an EEG, look at the top, you will find it written over there. So the next reference montage is a unipolar or a monopolar montage. So herein, as I said, that all the left hemispheric electrodes are given, the channels are in reference to A1, which is that side electrode on the mastoid process, left mastoid process, and the right hemispheric electrodes are reference to the electrode A2, which is on the right mastoid process. So this is how a typical unipolar montage looks like. So here, if you see this option, here is the option that you can select montages. And if you see here in the red color, you have the right-sided electrodes in reference to A2. And here on the below, you have all the left-sided electrodes in reference to A1. So this is how typically a unipolar montage looks like. So whenever you're trying to look at an EEG graph, whether on the computer or in paper, try to look at what are the channels displaying. And if you are seeing half the page as A2 and half as A1, then that's when you are dealing with unipolar. And if you are seeing all as average, that means you're dealing with the average reference montage. So the next broad category of montage is bipolar montage, wherein you have the chains in longitudinal, transverse, or circular fashion. So what do I mean by that? Here in bipolar montage, you will have the electrode be in reference to another electrode. I'll show you that. So, this is a typical bipolar montage wherein FP1 is in reference to FP2, F7, F3, F3, CZ, like that. And herein you are trying to see a phase reversal. So the phase reversal is at F4. The common electrode is F4. So the localization may be right frontal. Let's discuss more about it. So this is a photograph from a book called Ebazole, and herein I'll try to explain what is the main difference between referential and the bipolar montage. So here, if you see a view of the scalp, suppose you have a electric field here, and then you are having electrode placed at these 5 places, and these are the channels which are showing you the deflections. So here, if you have the maximum potential, as you move away, then you will have downward deflections. Here, if you're moving away in another direction, you will have upward deflections. And the site of maximum EEG potential, you will have a phase reversal in a bipolar montage. So pattern A and B are bipolar montages. C and D pictures are showing you reference montage. So if you look at picture C, the same EEG, focus of discharge, EEG discharges If you see in referential montage, you will get a upward deflection, which is of maximum amplitude in this electrode, in this channel. If you look at other channels, the deflection is not as large. So the highest amount of deflection, the electrode, the channel at which you're getting the highest amount of deflection, that you see in referential montage. And if you see a phase reversal in bipolar, then you can suspect a EEG focus to be there. Similarly, if you have a broader field, if you see these two electrodes are covered within the same field, then this channel may not show you actually any deflection, because you are subtracting the EEG potentials, and the channel above and below can show you a upward and a downward deflection. Wherein in an average reference montage or referential montage, those two EEG channels may show similar amplitude spikes. So this means that you are dealing with a broader EEG field. So if you look at the two major types of bipolar montages, longitudinal. So herein the chains are arranged vertically. So FP1, F3, F3C3, C3P3, and P3O1. On the right side, FP2, F4, F4, C4, P4, like that. So if you look at this EEG epoch, so one page that you are seeing, which comprises 10 seconds of record, it's known as epoch. So this epoch that you are seeing on my screen, if you can see that FP2 is showing with reference to F4, F4C4, C4P4. So this is a longitudinally arranged EEG montage. So longitudinal bipolar. This epoch is actually showing some good sleep spindles and vertices, which will be discussed in a subsequent lecture by Dr. Sonali. I will not go into these details. So transverse bipolar, now the channels are arranged horizontally. So FP1, FP2, F7, F3, F3, FZ, like that. Okay. So this is F8, F4, F4, FZ, like that. So again, this is showing the same sleep spindles and the vertices, but here the arrangement of the chains are different. So there is one phenomena that I would like to mention with reference to bipolar montages, which is end of chain phenomenon. So we discussed that in bipolar montages, we look at phase reversal. So if the peak negativity is at the end of a chain, for example, O1 or O2, you will not see a phase reversal, but just a negative or a positive deflection, because it is not showing with reference to any other electrodes. For example, at O1, if you look at the previous slide, then here O1 is with reference to T5. But if the EEG potential is maximum negative at O1, then you need O1 with reference to O2. So circular montage is of help during that time. It is also known as circumferential montage, which also shows you these end of chains with reference. So FP1 to FP2 or O1 to O2. So this is used to overcome this end of chain phenomenon. So as I discussed in the history slide, that we usually try to follow the ACNS guidelines in our EEG recordings. So what does the ACNS has to say with respect to EEG settings and these montages? It says that use of both bipolar and referential montage with at least 16 channels incorporating all the 21 electrodes of the 1020 system should be used. So ideally, when you are reporting a EEG or when you're looking at the EEG graph, you should try to change and see the montages. So for example, in reference montage, you are seeing a spike in wave. You should always go to the bipolar montage and confirm it with a phase reversal. So try to see the EEG in at least one bipolar and at least one referential montage, and try to see that all the 16 channels are visible to you. That should be clearly labeled. There should be clear labeling of each channel of the montage by electrode derivations. And usually how we place in the graph, the anterior derivations are placed above the posterior, and left are placed above the right. Okay, and try to include a ECG channel as well. So what are the common frequencies that we see in EEG? We see delta below 3.5, theta, which is 4 to 7.5, alpha 8 to 13, beta 14 to 30, and gamma above 30 hertz. So typically the EEG that we are recording is limited to less than 30 hertz due to attenuation by the skull bone. and discharges are rarely detected if they encompass less than 6 centimeters square of the cortex. So, and if so, invasive EEG is actually better for detecting the gamma and the high gamma oscillations. But for basic EEG recording, if the less than 30 hertz is usually sufficient. And MEG uses magnetic signals, which are less prone to attenuation, so more sensitive to higher frequencies. So coming to the basic operational controls and the settings of a EEG. So what are the main settings that we should look at? Sensitivity, high frequency filter, low frequency filter, the notch filter, the paper speed, and of course, all the recordings should be made by trained technologists and should be interpreted by trained physicians. And look, with respect to child neurology, the person recording and interpreting should be well versed with children and recordings in children and interpreting the pediatric EEG records. So coming to the first setting that you should look at is sensitivity. So what do we mean by sensitivity? The magnitude of the input voltage required to produce a standard deflection in the recorded trace. It is measured in microvolt per centimeter or microvolt per millimeter. The routine EEG sensitivity is 7 to 10 microvolt per millimeter or 70 to 100 microvolt per centimeter. So commonly used one is, try to remember, 7 microvolt per millimeter. So if you look at this EEG epoch, if you look at the sensitivity, this is 7 or 7.5 microvolt per millimeter. So try to visualize these EEG waves. This is again the same epoch. These are the same vertex waves and the EEGs, the sleep spindles that we saw earlier. But look at this now. If the sensitivity is 15, you see it. You see that the amplitudes have reduced. You see things maybe a bit more clearly. But ideally, while looking at the EEG records, you should use a sensitivity of 7 or 10. And if it is required to look at a phase reversal, or if it is required to look at the localization of these discharges, then you can try to reduce and see. And actually, this is the benefit of looking the EEG at the computer. So ideally, all the EEG records should be looked at the console for reporting and treating the child, rather than looking at paper, because on paper, you cannot alter these settings. You cannot alter these montages. So coming to the next EEG setting that you should look at are the filters. The low frequency filter, which should not be higher than 1 hertz. High frequency filter, no lower than 70 hertz. Notch filter, which is a 60 hertz filter. It is usually off and should be used only when the other measures against this interference fail or in ICU settings. So if you look at this EEG epoch again, so this is the low frequency filter, which is set at 1 hertz. This is the high frequency filter, which is set at 70 hertz. And so these filters are actually filtering the artifacts. The low frequency filter is filtering the slow waves. The high frequency filter is filtering the high frequency artifacts like muscle artifacts, etc. And the notch filter should be ideally off. So whenever you are trying to look at a EEG graph, make sure that your settings are right. Your low frequency filter, high frequency filter, sensitivity, the notch filter, and of course, look at the montage derivations. And the very important setting, which is paper speed. So paper speed should be 3 centimeter per second or 30 millimeter per second or a digital display of 10 seconds per page. So let us look at how this paper speed alters the record. So in this epoch, you see that the paper speed is 30 millimeter per second, which is the recommended one. So herein you are seeing some discharges here, or maybe here and here as well. And if you make it 7.5 millimeter per second, so graph becomes squeezed. You are seeing more number of epochs. So you are probably seeing those discharges as more, but you're seeing those discharges, more discharges in less amount of paper. So let me show you one more example. So this altering this paper speed is particularly useful in looking at children with SSP. So we all know that we usually see these GPETs, these generalized periodic epileptiform discharges in SSP. So in this one epoch, while we are discussing this epoch, can participants try to look at the EEG montage, and can they try to type in what sort of montage is this? FP2, F4, F4, C4. So while I describe, you can try to type in the montage if you have already identified it. So this is in this 1 10-second epoch, you are seeing these slow wave complexes, 1, 2, and 3. And if you want to look at periodicity, if you want to look at, are they actually coming at quasi-periodic intervals, then you can try to reduce the paper speed. And here, if you reduce, so if the paper speed here is 30 millimeter per second. So, okay. So this is again 30 millimeter per second. I see some responses. You are right. So that is a bipolar montage. So the basic bipolar montage, very happy that you could all identify it. Can you identify this montage? The top half is showing A2 with reference to A2, and the bottom half is showing with reference to A1. So while I discuss, you can type in your answers. Yes, unipolar. So it is a referential montage. And which type of referential montage? That is unipolar. Yes, so I have a very active audience, very happy to see that. So again, you're seeing these periodic complexes, these 3 complexes in 1 10-second epoch in this unipolar montage. And when you reduce the paper speed, here the paper speed is 8 millimeter per second. You see so many of them, and you are seeing that they're actually coming at certain intervals. So reducing this paper speed is particularly beneficial in SSP. So again, so this was the epoch with the unipolar montage, and this is the epoch with the bipolar montage. So coming to the next part, what is the duration of EEG recording? So as per the ACNS guidelines, you should have a minimum of 20 minutes of technically satisfactory recording. So I would like you to take note of this word, technically satisfactory. So if you have a 20-minute record which has too many artifacts, then actually the record is because you have right in the have a minimum of 20 minutes, and there are many studies on this area whether a normal EEG record.
Dr. Gupta, your voice is not clear. We cannot hear. Dr. Gupta, you are not audible.
Juhi, you're not audible, Juhi.
Hello, Dr. Juhi. Your voice, it has reduced the volume.
Am I audible now?
Not very audible.
Dr. Gupta, you are not audible to the audience.
Hello, am I audible?
Now audible. And
Okay.
you, last 2 minutes you are not audible.
Okay, I'll go back to those slides. So, sir,
Yeah.
am I audible now clearly or now?
Yeah, clear.
All right, all right. So, were the SSP slides audible or no?
The first slide was audible. After after the first slide, SSP slide, it was not audible.
Okay. So probably I'll repeat, and I'm sorry for this interruption. And please let me know if I'm not audible again. Then please let me know. So I'll just take you through quickly through these slides, and I'm almost actually towards the end of my presentation. So as I was saying, that the reducing the paper speed is particularly helpful in disease entity called SSP. So in this epoch, you are seeing 3 generalized periodic epileptiform discharges. So if you reduce the paper speed, then you are able to see many of them in one single epoch, and that's how you can try to look at the periodicity. So reducing the paper speed is particularly helpful here. Yeah, I hope I continue to be audible.
Yes, you are audible.
Okay.
Yes.
Okay. So as I said that, so now that you have learned about montages, electrodes, and the settings of filters, paper speed, and sensitivity, now what should be the duration of EEG recording? So they say that a minimum of 20 minutes of technically satisfactory recording. So I would like you to take note of this word, technically satisfactory. If your record is, let's say, of 20 minutes and it has a lot of artifacts, then the record should ideally be repeated. Minimum of 20 minutes is required. And there are a lot of studies going on in this area that whether higher records have higher yields. And many a times actually in epilepsy monitoring units or even otherwise, longer records of few hours or even up to 24 or more hours is taken to localize the seizures. And they, in a prospective observational study, it was seen that if you record 45 minutes EEG, then it has a higher yield than a 30-minute record. But practically, a minimum of 20-minute record is required. So what are the essential features that you report on an EEG? You try to report the waveform matrix, looking at the frequency, polarity, amplitude, morphology, and the duration. And you try to comment on the symmetry, reactivity, appearance, and synchrony of the discharges. So what are the activation procedures? So as Madam Kalpana Datta Madam was referring, that what you should write while asking for a EEG to be done. So apart from sleep and awake, there are certain activation procedures. Sleep itself is an activation procedure that can be asked for in an EEG. So you can have hyperventilation, photic stimulation, sleep and sleep deprived EEG. So in hyperventilation, child is instructed to breathe deeply at a rate of 15 to 20 deep breaths per minute for 3 to 5 minutes. And with children, it is very difficult sometimes to make them cooperate. So you can actually bring a pinwheel or a paper, colorful paper, and you can ask them to blow at the pinwheel. For photic stimulation, the distance between the stimulator and the patient's nasion should be approximately 30 centimeters. 10 seconds trains of flashes for each frequency are used. The photic stimulation range, you start from 1 Hertz and you go up to 30 Hertz. The normal response is photic driving, and the abnormal responses are photomyogenic response and photoparoxysmal response. I think they'll be covered in subsequent talks. And sleep and sleep deprivation EEG. So they say that epileptiform discharges increase with sleep by 30 to 70%. So when you are writing EEG for a child, you may request for an awake and sleep record. Sleep can be natural or can be induced by drugs. And the awake record, especially for primary generalized epilepsies like absence epilepsy, you may request for hyperventilation and photic stimulation during the awake record. And an activation yield of 10 to 30% is achieved with sleep deprivation beyond the effects of sleep, and overnight sleep deprivation or waking up the child very early in the morning may help. There are certain contraindications of hyperventilation, which is recent intracerebral hemorrhage, significant cardiopulmonary disease, sickle cell, or moya. Now coming to the last part of my talk, which I feel is very clinically relevant, that what are the indications of EEG? So I think we have a lot of postgraduate students on board with us today. And I would like to emphasize this point that seizures and epilepsy are diagnosed on clinical grounds. EEG is not a tool to diagnose epilepsy. It is all clinical diagnosis, and EEG supports the diagnosis, and yield of a standard EEG is 30 to 50%. So a normal EEG does not rule out epilepsy. So what are the indications when you should order an EEG? You can order when you are to differentiate between an epileptic or a non-epileptic clinical event. Of course, after a thorough history, looking at the home-based videos. In today's times, a lot of patients are carrying home-based videos, which are very, very useful to the diagnosis. And still, if you're doubtful, you can try to record a EEG. You can try to take a ictal EEG or try to induce the child. In those patients, EEG can be useful. To classify the type of epilepsy into focal or generalized, diagnosis of various electroclinical epilepsy syndromes, like we named West syndrome or Lennox-Gastaut syndrome in the beginning. Recognition of photosensitivity to diagnose non-convulsive status epilepticus, and in children with cognitive or language regression to rule out a clinical entity known as ESES, electrical status epilepticus in slow wave sleep. And then you can use EEG before tapering the drugs, monitoring the patients in ICUs with convulsive status epilepticus to prognosticate epileptic disorder, for example, like we saw periodic complexes in patients with SSP or triphasic waves in a sick child in ICU, to look for resolution of hypsarrhythmia. This is another important indication that if clinical spasms have stopped in a child with West syndrome, you should do an EEG to look at electrographic resolution. Then, of course, ictal video EEG monitoring to localize the epileptic focus in case of focal epilepsy. What are certain other indications to guide about etiology in a case of meningoencephalitis? So if you find pleds in a case of herpes encephalitis, and ancillary documentation for brain death. When not to use EEG, so as I said, to exclude a diagnosis of epilepsy. It is a clinical diagnosis to monitor the progress of epilepsy. If your patient is doing well, seizure-free, then there is no indication of doing a repeat EEG to look at the progress, to monitor the efficacy of anti-seizure medications, except in certain special situations like West syndrome that we have discussed, or ESCS, LKS. In case of ICSOL without history of seizures to form a basis to start the drug, EEG should not be done. And clinical history that clearly states non-epileptic disorders. For example, you have a child with shuddering attacks. Then you do not always require an EEG to confirm your diagnosis. The timing of EEG, so ideally should be done within 24 hours of a seizure, should be followed by a sleep-deprived EEG if deemed necessary. The yield in first 24 hours versus after is the yield in first 24 hours is higher, but many a times patients do not reach us that quickly. So when the patient reaches you, thereafter, you can do the EEG. This prospective study that I was talking about, that the yield of EEG, if they did a longer recording, that is more than 45 minutes, they could find a higher yield. So what are the take-home messages? Digital EEG is the standard of care. The electrode placement system is known as the 10-20 system. The routine setting that you should look at is the sensitivity, which is 7 microvolt per millimeter. The low frequency filter should be no higher than 1 hertz. High frequency filter no lower than 70 hertz. The paper speed should be 30 millimeters per second. And knowing at this point that epilepsy is a clinical diagnosis, EEG should not be done to rule it out. So I would request all of you to attend our upcoming International Child Neurology Conference in May 2024 in Cape Town, South Africa. And for more academic sessions, you can follow us here. Thank you.
Thank you, Dr. Juhi. It was an excellent lecture on your part. She has taken up the indications, the machine settings, and all the introductory information about the montages of the EEG. And I also thank her for correlating all these events with the clinical settings. So it was a wonderful lecture. And I would now request the Honorable Chairperson, Madam, Dr. Sangeeta Yoganathan, to tell whatever she wants to regarding this topic. Madam, Chairperson, Madam, please.
Thanks, Juhi, for taking us through in a very systematic way. You have covered up the history and then the basics of technical aspects of EEG recording, the electrode placement international 10-20 system. And you also have discussed very nicely about the type of electrodes, what are the reference electrodes and additional electrodes that are used in clinical practice. And you have discussed about the montages as well, bipolar montages, referential montages, and Laplacian montages. And also you have discussed about the ACNS guidelines for an ideal EEG recording in the clinical practice and the steps of recording as well. And you have gone through the other technical aspects like amplification sensitivity, filtering high filters, low filter settings, and the impedance of electrodes, and the paper speed, and the use of notch filters, and also the biocalibrations as well. And also you have discussed about the various indications when to use EEG in clinical practice and what to order, and what are the ideal activation procedures, that is the minimal activation procedures that has to be requested when a clinician is asking for an EEG. So you have beautifully covered all the aspects of the basics. So are there any questions for the speaker? We can take up that.
There are a few questions, Dr. Sangeeta.
Yeah, sure.
Just take the questions.
Dr. Das, please ask the questions so that Dr. Juvi Gupta can answer all those.
Yes, sir.
Yeah, Juvi, yeah.
There are certain questions. What is the sedation of choice in case of sleep EEG?
Okay. I think I also saw this question chat box, and I will actually thank the Dr. Anupama Gude who asked this question, because midazolam should not be used for sedation in EEG recordings, because it will affect the cortical discharges. And this is so even our residents, when we ask for a EEG and the child is not sleeping, they sometimes give midazolam. So it will affect the discharges, and midazolam and all the IV anesthetic agents should not be used. What should be used is oral sedation. You can use melatonin, you can use pedicloral, which is triclofos, and in some cases maybe hydroxyzine. The safest would be melatonin. It is available in syrup form and it is available in tablet form. You have 5 ml has 3 mg syrup, and 3 mg tablets are also available. And most important part in children for sedation is the counseling. So while we are requesting for an EEG, we can counsel the parents that this test will require your child to sleep. So be prepared for that, and they can wake up the child little prior to the usual time of waking up. And then thereafter, when they reach the site at the right time, they can give the sedation, which may facilitate the sleeping.
Thank you, Dr. Jupi. And there's a second question is that please throw some light on the neonatal montage and the role of impedance. It is a question from Dr. Ranjit Kumar Manokaran.
Yes, I think I missed showing the neonatal montage. So neonatal or pediatric montage uses fewer electrodes. So as I said initially that we use 21 electrodes. So neonates have smaller skull. The head circumference is small. And it is many a times, and even in preterms. So many a times it is not feasible to apply all those 21 electrodes. So neonatal or pediatric montage is the montage wherein we use limited electrodes, and it is used in children, preterm, newborns, and children with smaller head size.
Ranjit has also commented that intranasal dexmedetomidine is also being used as an agent in the ambulatory sedating agent in the EEG recording. So yeah, as Juhi was mentioning, the commonly we use triclofas. So if there was a time when there was a short supply of triclofas, and then we were using hydroxin as an alternative, and we have done a randomized control trial comparing the efficacy and safety of hydroxin versus triclofas, and we found that hydroxin was a good alternative for triclofas if it is not available, and it is a cheaper agent which is widely available as well. So there are a few other questions.
Yes, madam. Another question is the role of impedance. The role of impedance.
So as I said, impedance should be checked for the electrodes, and the inter-electrode impedance should be less than 5 kilo ohms or 5,000 ohms.
Yes, definitely. And another question is the dose of melatonin for sedation in pediatric patients.
So melatonin, there is no mg per kg dose. So the dose is, the syrup form is 5 ml has 3 mg, and the tablet is 3 milligram. So for usually younger kids, we give 5 ml. For older kids and adolescents, you can use 10 ml or 2 tablets of melatonin. For younger kids, we can use 5 ml or 3 milligram, 1 tablet.
Yes, and 5 milligram is also available, melatonin. The 5 milligram tablet.
5 milligram or 6?
Tablet.
Okay.
3 milligram and 5 milligram tablets, melatonin.
Okay.
And another, Dr. Chui, there is a question that is quantitative EEG.
Okay, so quantitative EEG is another neurophysiology test wherein, so in standard EEG, we are trying to look at electrical discharges from different brain areas. While in quantitative EEG, there is a mathematical and statistical analysis which is applied to those electrical discharges, and there are age and gender matched controls available with whom it is compared.
Yes, thank you. So it was an excellent session. I thank Dr. Juhi for her excellent presentation. And with the permission of the chairperson, madam, should we go on to the next session?
Please proceed, Dr. Sumit.
Okay, thank you, madam. So I would, after the first session of Dr. Juhi Gupta, we would like to move on to the next session by Dr. Sonali Singh. And I would request Dr. Sonali Singh to take up this session. Yes, Dr. Sonali, your slides are visible. You can start, please.
Hi, yes. Good morning, Dr. Suman. Good morning, good evening to everyone. Sorry, I'm confused with my time here. Now, I'd like to thank West Bengal IAP for making me part of this wonderful initiative. I'm actually happy to be a part of it. Now, the topic that I'm going to cover is EEG normal patterns and artifacts. So let's begin by saying, what do we pick up on EEG? So EEG picks up the brain activity, but it also picks up at the same time activities which are external to brain. Now, the activities which are produced by brain and picked up on EEG can be of three types. Either it is the baseline activity, which we refer to as the EEG background, or there can be a few transients which just pop up on and off in the jutting into the normal background activity. Now, these are called transients, and these transients can be physiological as well as pathological. So for today's topic, what we are going to talk about is the normal baseline brain activity, which will be reflected as the normal pattern or the background of the EEG, and few of the physiological transients, which may look abnormal because they suddenly stand out from the background, but they are actually physiological. Now, moving on to EEG activities where the... Hello?
We can hear you, Sonali.
Yeah, we
Oh,
can hear
okay,
you.
okay.
Please continue.
Okay.
Please continue.
So when the source of these activities is external to brain, those are the activities which we refer to as artifacts. Now, artifacts do not help us in making a diagnostic impression, but yes, it is very important to know about the artifacts because they may be misdiagnosed and they may be taken as some abnormal finding, which it actually is not. So the objectives for today's talk is to identify which is normal, what is normal, to have a brief idea about the age-related changes, because as we know, when we come to pediatrics, everything has age-based norms. So is the same for EEG. And finally, to differentiate seemingly abnormal pattern from true abnormalities. So this includes the benign variants or the benign transients, which is the activity produced by brain, as well as the artifacts, which is from external source other than brain. So when we talk about normal pattern, if I want to put it simply, the normal pattern is age-related. So as I already mentioned earlier, in pediatrics, we have everything which is modified because of age. So we have age-related changes, which in itself is a big topic. But yes, I will like to touch a few points as we move on in the presentation. The most important thing that I'm going to talk about is state-related. So what do we mean by state-related? So I'll just put it simply. The recording may be done in any physiological state. That is, it may be awake, it may be drowsy, it may be light sleep, it may be deep sleep. So if you want to talk about that this EEG has a normal background, a normal pattern, we should correlate it with the state in which it has been recorded. So let's talk about the awake normal EEG. So when we look at the EEG, which I'm going to show in subsequent slides, what we are looking at is what is the background frequency, what is the background voltage, Morphology, that is, how does it look like, how long does it stay, and where in the brain exactly is it localizing to. Like as we've already seen in Dr. Juhi's presentation, which has made my work a little easier, we have these different brain regions. So normalcy depends on these factors. In the subsequent slides, what we are going to see is we call an EEG normal if we are able to see an anteroposterior gradient. Now, what do I mean by anteroposterior gradient? That the background activity will have a gradual increment in the voltage as well as frequency as we go from front to back. Second is posterior dominant rhythm. Now the posterior dominant rhythm, because the background activity increases as we go posteriorly. So of course the frequency in the posterior head region, predominantly occiput, is the maximum. And this gradient and this posterior dominant rhythm, this is called the posterior dominant rhythm. I have mentioned here alpha range because that is what we usually find in adults or children beyond 3 to 5 years of age, because that is when they reach alpha range. Now this posterior dominant rhythm, which we are giving so much of importance to, is best appreciable in a relaxed wakefulness. So patient is lying relaxed with his eyes closed and is relaxing well. So that is only when we will be able to establish and see this posterior dominant rhythm. If the person is not relaxed, this dominant rhythm will not be appreciable. Now, next thing to call it normal is that there should not be a variation of more than 1 hertz side to side difference. So left and right PDR, or the posterior dominant rhythm, should not have a variation of more than 1 hertz. Now, as we already spoke, that it is best appreciable when person is relaxing. So relaxed wakefulness, so it gets attenuated in response to eye opening. So once the person opens his or her eyes, this background gets attenuated. Right hemisphere is usually slightly higher than the left. However, we do have the physiological variation beyond which it may be termed abnormal. And this background rhythm can be sinusoidal. So whatever points we discussed, let's just try to see it over the next couple of EEG epoch examples. Just to touch upon the pediatric changes, so this posterior dominant rhythm is not well appreciable before 3 to 4 months of age. It is around this time that this anterior to posterior gradient starts appearing. Now, as far as the frequency part is concerned, one easy formula that we usually use during our training period is age plus 1. So if you have a 1-year-old kid, and if you're finding a background of 4 hertz, up to it is normal. If it's less than that, it's abnormal. So by 5 years, it reaches to 8 hertz, 10 years, 10 hertz. So that is how it progresses. So let's see this epoch. So here, as we've already seen, here we have bilateral electrodes mentioned. For ease, the blue ones are left-sided, which also have these odd number annotations. And the red one is right-sided, which has the even number annotation. And all these blocks of electrodes are antero-posteriorly placed. So here we have F, frontal, temporal, occipital. So we have the most lateral group of electrodes. So here, this is anterior to posteriorly placed. Again, frontal, temporal, occipital, right-sided most lateral group of electrodes, anterior to posterior placed. This is fronto-central parietal occipital, which is parasagittal, left-sided parasagittal electrodes, anterior to posterior, and similar on the other side. What we are going to look at is, it is very clearly obvious that the amplitude increases posteriorly, the frequency becomes more prominent posteriorly. So it is a well-established posterior dominant rhythm. Now let's count the frequency. So we are looking at O2, which is the most posterior of the right-sided, and O1, which is most posterior of the left side. So right side, if we count it, it is like 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So it's around 10 to 11 hertz. And if we look at the left side, similarly, it is around 10 to 11 hertz. This bar here just shows that the time point between the two green lines is 1 second. So that is why we are calling these posterior dominant rhythms to be 10 to 11 hertz. And this y-axis is what denotes the voltage. So we can see that this posterior rhythm is approximately 70 to 100 microvolt, which is normal. So this is a well-established posterior dominant awake rhythm in a relaxed wakefulness stage. Now, as we go ahead, we will realize, wow, besides these alpha rhythm, which we are seeing posteriorly, what are the other reasons? Why am I calling it relaxed wakefulness? Because otherwise we would see some eye blink artifacts over the frontal electrodes, and we would find some amount of muscle artifacts. So when the patient is a little anxious, is tensing his muscles, we find muscle artifact as well as the eye blinks. Now, the second point that we spoke about was that this well-established anteroposterior gradient gets attenuated when one opens his or her eyes. So let's see, how do we know when is the eye open and when is it closed? So in this epoch, this mid portion is where the background appears to be most beautifully organized in an anteroposterior format. So let's see. Here, these are the ocular electrodes, and the ocular electrodes are in this particular recording is placed just close to the frontal electrodes. So that is why over the ocular electrodes, this downward deflection that we are seeing is equally appreciable in the left-sided frontal electrode, right-sided frontal electrode as well. Now, this down deflection is actually eye closure. So after eye closure, we have a well-established PDR. And here we have the ocular electrode, which is showing an upward deflection, which is eye opening. And after the eye opens, this posterior dominant rhythm gets attenuated. Now, what is the logic behind these deflections, and how do we know that this is eyes closed and this is eye open? So what happens, as we've already seen, the electrode which picks up negativity shows activity which goes upwards, whereas the electrode which picks up a positive activity, it shows a deflection downwards. Now, cornea is positively placed and retina is negative. When we close our eyes, there's Bell's phenomena, and eye kind of goes up. So when it's going up, the electrode is actually picking up the positivity, which is closer to it. So that is why on eye closure, we have downward deflection. While when we open our eyes, there is a relative downward turning of the eye when the electrode picks up the negativity, which is now slightly higher up, and that is the eye opening. So this shows the attenuation of the posterior dominant rhythm with eye opening. Now let's see here, just an example. So this epoch belongs to a girl who is 9 years old, has repeated episodes of occipital semiology seizures, and on her MRI, she has a right occipital small gliotic area. So now what do we comment on the PDR or the posterior dominant rhythm here? This is O1. So we are concerned with this activity. And here is O2. So this is right occipital, this is left occipital. Now comment on the PDR. If we see the PDR of the left side, it is relatively well established. If we see the PDR here again, O1, this is well established. So we have a PDR of approximately 10 hertz. But now if we look at O2 here, O2, so this is right-sided occipital where we were supposed to have almost symmetrical and synchronous rhythm, but we don't appreciate it here. So this is definitely not normal. And in this patient, we can explain it because the child has a destructive lesion onto her right occiput. That is why the activity there is slowed, not as reactive as on the other side. So this is one epoch, but I'll just show you this girl also has this repeated spike and wave thing happening here. So this is just to show that atypical or asymmetrical PDR actually gives us a clue that there might be something happening on the other side. Now, this epoch I had presented mainly for the purpose of showing asymmetric PDR and its importance, but at the same time, the other things which are evident in this epoch are a couple of artifacts. So we have these fast activity happening here over the temporal region. So this is usually found if the person is tensing his or her muscle onto that side. So this is one artifact. Plus we also have these eye blink artifacts, and we have some subtle amount of lateral eye movement, which will be better appreciable onto the other subsequent slides. So that was more or less a normal awake record, what we see, and how to identify the abnormalities on the awake record. But besides this normal background pattern, you can have certain transients. So there are actually a number of transients which may occur in awake, but the most common ones which we find on EEG, I'll just show them as example. So we have mu rhythm and PSY, or the posterior slow wave of youth. So let's see what's that. So here we have an epoch. As we can see in this epoch, the posterior dominant rhythm is not very well established. We do not have those typical eye movements and muscle artifacts. So maybe the person is not alert and awake or completely to see that posterior dominant rhythm, or wakefulness, eye blink, muscle artifacts, etc. Plus, another thing that is evident in this epoch, which we will see all the more better later, is this sinusoidal, smooth contoured form of wavy activity happening over the frontal electrodes, which is all the more a little better appreciable over these ocular electrodes. So we have these sinusoidal kind of thing happening. So in any ways, this patient may be slightly going towards a drowsy state, but what is to be seen in this epoch is this activity. So we have this activity. Where is it happening? It's happening over the central electrode. So this is C3 electrode. So this is central activity happening. It is most prominent unilaterally, though there is some activity happening also onto the contralateral side, but it is mostly central in localization. And the frequency is almost of the alpha range. So this is what we call a mu activity, which is actually a benign variant. It looks sharp, and because of its location, it may appear as if the person is having some sharp activity going on in this region, but this is actually a benign variant. And unlike the alpha rhythm, which gets attenuated by eye opening, these mu rhythm is unaffected by opening or closure, but it gets attenuated if somebody is thinking, on touching, or some motor activity. And it is actually said that mu rhythm in a particular person will have its frequency almost similar to the alpha rhythm of that person. So this is a benign variant. Now let's look at this epoch. So on first impression, we have a very well established anteroposterior gradient. We have good frequency of the posterior dominant rhythm. But overall, what strikes us is probably this activity, which kind of gives us an appearance as if there is a sharp up deflection and there is some slowing. There is some sharp up deflection and there is some slowing. So is it abnormal? No. So this is actually posterior slow wave of youth. And the best way to identify it is that it just appears jutting it into the normal rhythm of alpha. So there's this alpha going on, and in between suddenly you see a slowing and there's alpha going on. So this is what posterior slow wave of youth is, and this is actually a benign transient. Now related to the awake record, I'll just show one last example. So this epoch is of the same child where I had demonstrated the asymmetric background, asymmetric rhythm. So here also what we can appreciate is that alpha rhythm is, posterior dominant rhythm is very well appreciable over the left side, but it is not appreciable over the right side. But in general, this is what her awake record looks like. Now let's see, after some time, this is what happens. Okay, so our first impression, if somebody is seeing this epoch, would be that this is definitely abnormal. So what we can see here is that the background activity, which was that of a PDR, is now gradually replaced by this buildup of theta and delta, which is more prominent over the posterior head regions. So what has changed? This was the time where hyperventilation was begun. So this is a physiological response to hyperventilation, and this is definitely not abnormal. But yes, sometimes we may, this hyperventilation is what precipitates typically absence seizure or any form of epilepsy, or interictal discharges may get aggravated by hyperventilation, because this is one of the activation procedures, but we should actually be careful in identifying it as a physiological or a pathological variant. So this is an HV induced physiological change. We see the buildup of theta and delta. This is more robust in children. In adult, it tends to be frontally predominant, while in children, it tends to be predominant in the posterior head region. So this is more or less, we are done with the awake normal pattern and few examples of common benign transients that we see, which may look abnormal, but they are actually normal. So now moving on to sleep. If you're having, so as Dr. Juhi had already mentioned, a normal routine EEG is that of 30 minutes record. So OPD record. Now we know a sleep cycle is of 60 to 90 minutes. So in a routine 20 to 30 minutes record, sleep record, we will mostly find maybe stage 1 and stage 2. Probably the REM and stage 3 may not be appreciable. But the good thing is that the ones which are available are the ones which give us maximum information. So we are happy with a 30-minute technically satisfactory record, sleep record. So what are the changes that happens as one transitions from awake to sleep? Let's first think about NREM1. So we have seen that in relaxed wakefulness, we have this good posterior dominant rhythm. We have a nice alpha background. So as patient starts becoming drowsy and transitions toward NREM, what happens is there is fragmentation and attenuation of alpha rhythm. So that beautiful rhythm starts getting fragmented and becomes less and less prominent. Plus the muscle artifact and the eye blink artifacts, that is the vertical eye blink artifacts, they start getting attenuated. So they are no longer there. The alpha frequency gets replaced by a mixed frequency. So we have kind of theta, delta, kind of a mixed frequency. And towards the end of NREM1, we can actually start seeing the vertex waves. Now, because this topic is covering all the normal, so rather than pointing it out separately, I will mention it right here that around NREM1, when it goes towards the end, we can also appreciate something which is called as posts, or the positive occipital sharp transients of sleep, which look quite sharp and spiky, may look abnormal, but they are actually normal. May or may not be found in everyone, but the first couple of findings that I mentioned, that happens in NREM1. Now, as patient progresses from NREM1 to NREM2, the sleep markers become more prominent. We have sleep spindles and K complexes coming, plus the previous findings of NREM1, that is gradual slowing, loss of muscle artifacts, they continue to wane off. And finally, we have NREM3, which is basically high amplitude slow waves, which we find, and the sleep markers may not be very well appreciable. So as far as the pediatric part is concerned, this well-established sleep architecture is not appreciable in very young children. It's around 3 months, that is when a vertex is expected to come into picture. And by 6 months, we start seeing the spindles. The initial records may show asynchronous sleep markers. So asynchronous means not happening at the same time on both the hemispheres. Sleep markers tend to be of longer duration, and it is around 18 to 24 months of age, that is, the sleep markers start getting synchronized. So with some examples, let's see the transition. So here again, I have put in 2 examples. one of the girl with that asymmetrical PDR and another a perfectly normal EEG. So here, this is an awake record. How do we know it? We have the muscle artifacts, plus we have these eye blink artifacts. So this person is awake, this person is blinking frequently, this person is tensing his or her muscles, and we have all these artifacts. This person is awake. So this was eye blink, and these are the muscle artifacts. Now, here, the change that we are seeing is probably now the person is a little more relaxed because we see this alpha posterior background appearing. So probably this is relaxed wakefulness. Plus, we also see that the muscle artifacts have gone down. It is not as that fast activity which we were seeing earlier. As we move further, ignore these epileptiform activity. What we find here is, yes, now there are no more eye blinks. We do not find much of muscle artifacts. Plus, right now what we see is this sinusoidal activity happening over temporal electrodes. So basically anterior temporal, when we have up and down movement of eyes, that is picked up as eye blink, which is picked up over the frontal electrodes. But once you are transitioning towards sleep and you have that roving, slow, sideways movements, that is picked up in the anterior temporal electrodes. So that is why we are seeing this sinusoidal roving eye movement kind of an activity over the temporal electrodes. Plus, if we look at this area, kind of the background does not appear to have so much of anterior to posterior gradient and looks kind of mixed. So that was one example. That example I had put up because I wanted to show the artifacts and how they are transitioning into sleep. However, this example is that of a normal EEG from awake to sleep transition. So here in this record, we have a well-established PDR. We have a nice PDR. Person is with his eyes closed. It is relaxed wakefulness. Now, as we transition further, here what we see that perfectly beautiful PDR is not appreciable. And here we kind of see a mixed frequency background. Plus, as is evident on these ocular electrodes, there is this roving eye movement. So we have some slow roving eye movement. We have attenuation of alpha. We have mixed frequency background. There is not much of muscle artifact. So this person is getting drowsy. Okay, now another thing that I'd like to show you here is, so we have this roving eye movement, which is prominent here. So which electrodes are these? So these are left temporal electrodes. And again, the roving eye movement on the right side is most appreciable here. So this is right-sided temporal electrode. In this roving, slow roving eye movement, we have a phase where the two waves are far apart, and we have a time when the two waves are opposed to each other. And what we see is this opposing together on one side is moving away on the other side. So the wave which is apart from each other is the side to which eye has moved. So here, because on the right side, this is apart. So that is why eye here is onto the right side. Here, the right-sided it's opposed together. So here the eye is onto the left side. So basically this is having this left and right roving eye movement. So this person is in NREM. Now this is still an NREM because we can see the slowly roving eye movements over the anterior temporal electrodes. We can see this mixed frequency. The additional finding is these sharply contoured, not very spiky activity appearing over central electrodes. So these are apparent over CZ, C3, and there is also something over C4. So over central head region, these starts coming. So this is basically the appearance of vertex waves. And of course, we've already seen the slow roving eye movement. Now we are further transitioning down because now we know that the sleep markers are a little better appreciable, but at the same time, what we can appreciate over the occiput is what we discussed earlier, also called as posts. are the posterior occipital sharp transients of sleep. So this is actually a normal finding. Now let's move further. We are further transitioning towards NREM2, and we can very well appreciate that the sleep markers are now a lot better appreciable than it was earlier. We can still see the slow roving eye movements. And here what we see is a well-established sleep spindle. So on a first impression, like the first time when we see this epoch, the first impression that we have that this activity is maximally localized in this region. Now, what is this reason? If we go on to our electrodes, so this is basically frontocentral, central, frontocentral, frontocentral. So we have it over the central region and both sided, left and right, central region. So this is a well-established sleep spindles. So these examples were just to show what is the normal pattern of transitioning from awake to sleep. Now, additional finding that you may also take note in this record is that of these transients appearing at regular interval. Now, what are these? If we look down, so these are almost time locked with the ECG. So these are basically nothing abnormal. These are just ECG artifacts because they are time locked with the ECG, which is also getting recorded on this patient. So this was the normal pattern of awake and sleep, plus a few of the common transients which we normally come across that I showed, which we usually get confused with something abnormal. But if we theoretically go to look into the benign transients, there's like a long list. And we have good pediatric atlas textbooks available. So the best way of learning these normal and benign transients is to look at it in EEG with the atlas in hand, so that when you're reading it at the same time, you can correlate. So I'm not going into the details of all the transients. Let's just leave it at this. But yes, the common ones have been covered. So let's move on to the artifacts. As I already mentioned, everything which is external to the brain activity is what we say as artifact. Now, this artifact outside the brain can be related to the person or to the environment surrounding. So by person, I mean artifacts which are due to cardiac, artifacts which are muscle artifacts, the ocular artifacts. So these are basically patient related, but external to brain. And then also we have environmental electrodes. So environmental artifacts means a sudden tapping or the devices, electrical devices nearby, ambient noise. So these all are into the environmental artifacts. So there are a number, there can be hundreds of sources of artifacts. The best way to identify an artifact is if you have a simultaneous video where you can see what is exactly happening to patient at that time or in the environment. But this is not a feasible thing when we are doing a routine 30 minutes of OPD recording. So even in that case, if we have a beautifully annotated record, so the technician who's doing it, if he keeps on putting annotations as to here the child was sucking, here the child was blinking, here the child was being patted by the mother or was being swayed sideways or something like that. So these annotations are very helpful in recognizing and labeling something as artifact if per se we are not able to identify those artifacts just by looking at them. So let's see a few common examples. So this first example that I'm showing you, so this is on to the left side. This is electrode T5. We see very nicely these spiky activity happening. And at first impression, we are definitely going to say that this is abnormal activity that's happening. But the thing to observe here is that these spiky activities onto the left side are easily time locked with the ECG marking which we have, right? So this is exactly time locked with the ECG, hence this is ECG artifact. Now, if this patient was probably not attached to ECG, we could still identify because the rate is such and the appearance is such, but we could not have been completely sure that yes, this is ECG artifact if along with EEG, ECG was not being recorded. Now look at this epoch. So here the thing that like literally stares you into the eye is this large sinusoidal, large amplitude, very low frequency activity happening. And this is happening in very O1. Okay, so this electrode, this is happening in O1, this is happening in O1. So this is a very large amplitude waveform without any field. So without any field means that it is not affecting the electrodes nearby. So it looks like something which is just exclusive to O1. So this is actually a lead movement artifact. And another thing to corroborate this finding is like when we look at the EMGs, we actually see the patient moving. So during this movement, one of the electrodes must have moved, and that is why we have this lead movement artifact. So placing EMG is not like very definitive. Just by looking at it, we could have said that this is lead movement artifact, but yes, EMG does give us more points in favor of calling it a lead movement artifact. Now let's look at this one. So one thing that looks very prominent is this fast activity happening only in the FP2 electrodes here. So again, because it is not affecting the nearby electrodes, it is limited to just one electrode. So it must be something which is particularly attributed only to that electrode. So this is actually an electrode artifact. And another artifact which we can see here, which we usually find in EEGs pretty frequently, is this one. So where you have a sharp down course and then you have a slow returning phase. So this is actually a lead pop artifact. So suddenly there was one lead which got disconnected, again got reattached. So we have this lead pop off artifact also here. So this spikiness should not concern any of us about it being a pathological finding. Now, when we look at this, suddenly we find too much of sinusoidal activity happening. This is actually a perspiration artifact. So basically, as Dr. Juhi had already mentioned, we record these activities on the EEG, which is basically a difference between the two nearby electrodes. Now, because of some reason, if these electrodes do not tend to have that difference, then the most logical thing to appear would be a flat line because there is no difference between the two electrodes. Now this, so when can we find this situation that there is no difference between the two electrodes? Either the two electrodes are placed in a way that they are touching each other, or the jelly which has been placed was so much that though the electrodes are a little apart, but through jelly, they have a connection, or the patient may be sweating. So those are the times when we see these artifacts. We have already discussed about the ECG artifact, but in this epoch, that ECG artifact is also visible. Now, this we've actually spoken already in the previous slides. So we have the muscle artifacts, we have the vertical eye blink artifacts. So up and down eye movement is this eye blink artifact, which we see in the frontal electrodes, and the slow lateral moving artifacts are what we see over the temporal electrodes. Now this EEG epoch is that of a neonate. And here what we find is this spiky needle-like activity followed by a slow wave. And they are occurring at a very rhythmic interval. So of course, anybody will get confused by looking at this activity. But once we reviewed the video, we saw that the child was sucking onto a pacifier. And this is basically a patient-related artifact. These are frontally placed, negative deflections. They look like eye blinks occurring at repeated intervals without much of a gap in between. So this is basically eyelid flutter, and it should not be confused with that of a something epileptiform. Now, this epoch has actually a number of artifacts, but what I'd like to point out is we have seen the slow roving eye movement, which we see in NREM 1. Here, what we can see is jerky lateral eye movement. So say somebody is reading a book, or maybe somebody is looking at some object which is moving to and fro. So we have the saccades where the person will look onto one side, then again correct, come back to the opposite side, and again sideways movement to the opposite side. So here the jerky kind of movement that we are seeing over the temporal electrodes, where there is a sharp upfront, then coming down, again upfront, coming down. Now the principle here remains the same. Where the wave is separated out is the side to which eye has moved, and the one which is opposed is opposite to it. But this is lateral eye movement artifact. So I am actually done with my presentation. So the normal take-home messages are that the normal pattern, which we call a normal pattern on EEG, actually age and state dependent, and pediatric EEG is little difficult because it has age-based norms. So the best way to read an EEG is with an atlas in hand, where we can actually look at the pictures, correlate, and decide. So it's reporting and learning. Now, besides these normal brain patterns, we can have certain transients which are originating from brain, but they can be benign variants. So they are not present always, maybe seen in few, but they actually have physiological implication and they are not pathological. Artifacts can be from multiple sources. So artifacts can be any source external to brain, which can be patient related, which can be environment related. The best way to identify artifacts is the more and more we look at it, we know to identify it by visual impression. But another useful source is to have a look at the videos. We do not have it, we can look at the annotations. So if the annotations have been put as to what exactly was happening during that time, we can look at the artifacts. And this identification of benign transients and artifacts is important because on many of the occasions, they get mislabeled as epileptiform activities. So I thank you all, and let's have happy EEG reading.
Thank you, Dr. Sonali. It was a wonderful presentation. I thank you for the plenty of illustrative EEGs which you have shown. It would make the reading of the EEGs more interesting, and also the PGTs would be able to identify at least the basic patterns. I really thank you for your wonderful presentation.
Thank you so much.
And,
thank you so much.
There are two questions. What is FZ and CZ? This is
okay,
one.
so yeah.
Please, and another thing is that in one of the slides there was right-sided occipital activities reduced.
Yeah. So do you want me to show that slide again? So first, so to answer the first question, if we just imagine it on ourselves, so anterior to posterior, we have a midline, right? So we have a central midline, as Dr. Juhi was pointing out, which begins from nasion to posteriorly over the occipital prominence. So that is the central line. The electrodes which are placed over there are labeled as Z. So we have FZ or FZ. Posterior to that is CZ or CZ. Posterior to that is PZ or PZ. Okay, we do not attribute any number to it because they are central. We attribute numbers only when we are referring to the electrodes which are away from central. So we have number 1, 2, we have the odd numbers for the left-sided. We have even numbers for the right-sided. So to answer that first question, FZ, CZ, PZ, they are basically absolutely central electrodes. And I'll show the
Yes,
occipital.
occipital reduced right-sided activity, but the person has not mentioned any. I mean, what is the actual query?
That's okay.
He
I'll
has just.
show the slide maybe. So what I was basically trying to show here is that onto the left side, O1, we have a nicely appreciable posterior dominant rhythm, while on O2, we do not have a very nicely appreciable posterior dominant rhythm. So this should alert us that maybe there is something going on onto the right side. And usually if we have a destructive lesion, like we have a gliotic lesion, old insult sequelae or something, the background onto that side appears to be slower, and amplitude wise, they tend to have lower voltage. So this should alert us to something going on onto the right side. And this was just to confirm that finding that this girl actually had discharges from her right occipital region, and on MRI she had that right occipital gliosis. So that was the reason why we did not appreciate PDR onto the right side.
Yes, thank you, Dr. Sonali. And
Thank you.
in today's session, Dr. Juhi Gupta, she has covered the indications, the basics of the techniques and the settings, and Dr. Sonali Singh, she has covered the normal patterns and the artifacts. And this entire session of today, this is the stepping stone for knowing what is normal, what are the variants of normal, and it is this will help all the participants to understand what are the abnormal patterns which will be dealt in the tomorrow's lecture. Now, I would request the chairperson, madam, to give her valuable inputs.
Yeah, thank you, Sonali, of the excellent presentation. You have clearly taught the residents how to identify the normal wave patterns and also the benign transients, and how to describe a background in EEG recording, how to identify the sleep markers based on the morphology, frequency, and distribution of the waves, and how to stage the sleep, how to identify the different stages of the sleep, non-REM and REM sleep. And the most important step in the interpretation of EEG recording is the recognition of artifacts, which you have beautifully covered in your talk. And also you have emphasized the need for vigilance of the technicians during recording, particularly in infants and children, because they're prone to have a lot of artifacts. And it is most important to annotate during the recording at appropriate situations like sucking, where you have shown a EEG recording where the sucking artifacts was mimicking like an epileptiform discharges. So I think it's a great fundamental learning for the residents today about the basic technical aspects, steps of recording, and identification of wave patterns and identification of artifacts. Are there any more questions to take up?
No, there are no more questions, madam. I really thank Dr. Juhi Gupta and Dr. Sonali Singh for being the speakers for today's session. I also thank Dr. Sangeeta Yoganathan for accepting the invitation and becoming the chairperson. Thank you, madam, for your excellent inputs. And over to the organizers of WBAP, because we have done with the session and the lectures and the question and answers.
Thank you, Dr. Das. And I must thank Dr. Sonali Gupta and Sonali Singh and Dr. Juhi Gupta. On behalf of WBAP, I request our President, ma'am, to conclude the session today. Over to you, Dr. Professor Kalpana Datta.
Okay, it's a wonderful session by Dr. Juhi Gupta and Dr. Sonali Singh. A nice sharing the session and taking you all the clues and summarizing by Dr. Sangeeta. And I also like to thank the moderator for nice moderation of the whole session. And once again, thank you for keeping in time and finish before time. We have not finished our time also. And there are lots of questions. I think it will be very useful for all of you. For all the participants, please go through it. You will get the, I think, YouTube channel, and you can revise yourself and go through the book and again see the sessions. It will be beneficial to you all. Thank you, and thank you all the Dr. Shapan Roy and Dr. Mihir for taking so pain to arrange all those things. And Dr. Jashodhara also I must thank. She has taken all the pain to communicate with all the speakers, presenters, and the chairperson, moderators, and all. Thank you all, and have a good night. Nice.
Tomorrow we'll be meeting at 8 p.m. and we will conclude tomorrow by 10 p.m. So please log in time tomorrow.
Yes,
Tomorrow
so
is Saturday, I
we'll
know.
meet tomorrow.
We are starting a
at 9
bit
PM.
late. And thank you, speakers, Dr. Juhi Gupta and Dr. Sonali Singh. Thank you so much.
Thank you, sir. Thank you,
Thank
ma'am.
you and good night.
Thank you.